Mike, can you comment on the risk status of this patient and how that might impact your choice of treatment for them?
So we kind of cheated. We gave it away. We did the math. But I think it's interesting that we still use a model that's quite old. I think the so-called risk model still is valid in a typical chronic phase CML patient, but we clearly have evolved models, particularly outside of the US, with European risk models that actually look at things beyond just the presenting features of the CML. They're able to predict survival, but we're looking for some gauges to response to therapy. So in this case, a so-called risk was calculated, and the patient is higher risk. I think the main features Dr. Smith pointed out. I mean, this is maybe not as simple and as benign looking a chronic phase CML case as you might expect. The white count is high. The blast count's a bit higher. I don't think, I think we heard that there was splenomegaly. So how does that impact your treatment? I think if you look at guidelines and look at available data, there may not be a mandate to treat a patient with higher risk disease by whatever model you use with a different therapy, but there's definitely a suggestion that you may want to consider that. Although all therapies are good, in typical chronic phase CML. So I'll open it to others for to comment on that point. But I think in a high-risk patient, you want to definitely think about more aggressive therapy, but not dismiss the fact that imatinib still could be effective.
The scores, it's hard to get them. You have to Google them. It's not like just IPSS. So you need to go online, do the formula, and get them calculated. Usually, at our institution, we have a database, and somebody will do it for you. But mainly, this patient presenting with a high disease burden, had a low count, had a high tumor burden, he's symptomatic. So essentially, these are patients who are high-risk disease and have big spleen. So the European came up with the UTA score, which is essentially simplifying things into the basophil percentage as well as spleen size, and these patients fit well into high-risk categories, regardless of which score you're using. It'd be nice to have a molecular signature as well, like we do with AML right now and other diseases, where we'll define the risk scoring system by more biology than what we've done before, knowing that the scoring system we have, they precede the era of tyrosine kinase inhibitors. And there's conflicting data about which one is still valid or not.
I agree with you. I think there's a lot of difficulty, especially the SOCOL score, as you mentioned, was developed in patients receiving interferon. I think the other challenge we run into is it's not as dynamic, so you can't use it later to kind of reassess where a patient is. It doesn't incorporate some of the important things we mentioned, like clonal evolution and other cytogenetic abnormalities, but it's kind of still where we're stuck. For that being said, would you have usually started with imatinib for this patient with high-risk disease, 62?
I think it's a loaded question. I think, I offered these options to the patients and talk about the relative risks and benefits. I don't say it's a bad choice. I think I might encourage a patient like this to be treated with as good a therapy as possible to obtain remission. But I think what this case is highlighting for us is that how do you choose therapy in the whole context of the patient and their comorbidities and what trouble might befall them, not just CML, inadequate CML response, but what about other health issues that could arise from therapy or as complications of therapy.
What's interesting, at our institution, we probably would actually have started a second-generation drug, or we would have leaned in that direction. There's not a lot of prospective data to really guide us there. A lot of it's retrospective. And if you look at this case, it's a real challenging one. I mean, the patient has a history of an infusion, so you think some of your second-generation drugs are associated. The person has a history of some cardiovascular risk factors, dysrhythmia. Some of your second-generation drugs have, black box warnings about, QTc prolongation. So you're really narrowing down your choices from a disease where we think we have lots of choices, 5 different oral drugs available, 4 of which are approved for upfront therapy. And suddenly you've begun to narrow them down to only a couple left. So I do think this is a really great case for discussing, but a real challenge because the patient's comorbidities really offer you to have to think really hard about what's the best drug to start them with.
You have, like you mentioned, Doug, you have 3 features. You have pleural effusion, you have heart issues, hypertension, and you have renal insufficiency with a clearance of 47. So essentially, all second-gen TKIs, each one of them has this issue here. And then you add to that the payers. I mean, he's 62. He's not yet into the Medicare, so he may have to have a copay, although a lot of assistance programs are available, but sometimes the choice is dictated by the payers. How much I'm willing to ask my patient to have a copay for new drugs compared to something we call today generics. Are they available? That is something to consider as well.
I agree. I think that often the challenge, especially with first-line therapy, is choosing the right drug for each patient. We're very fortunate in CML that we have a variety of options to choose from. But I would agree at our center with a high-risk patient at age 62, we'd probably have a tendency to start a second-generation drug. Based on the 3-month time point, though,
Yeah.
Mike, would you have done something different at that time?
But let me ask you a question. If you, and I'll ask everybody here, if we have to go for second-gen TKI, which one you would have chosen in the light of these comorbidities?
I was going to say, to set that question up, I think we have to be careful not to directly assume that these problems are going to happen on therapy. Does having a pneumonia and effusion mean you're going to have an effusion with dasatinib? Does having some minimal SVT and a QT of 450, which is actually quite
acceptable.
It's acceptable.
But you have hypertension too.
We have hypertension, so that could be another issue. And what does renal insufficiency mean? I think that's probably the foggiest of the comorbidities with regards to the implications for TKIs. But you're right. I mean, I think we have to choose, or we have to choose with our patients. So.
And that being said, when you use TKIs in the front line, the dose is lower than relapse setting. That is the case for example, bosutinib, nilotinib as well. And we have data on dasatinib with a lower dose showing equal efficacy. So I think we have room to adjust the dose if we go for second-gen TKI.
I'll put my quarter down first because I'm supposed to be looking after this case. And I think dasatinib wouldn't be an unreasonable choice here, because I might not assume that the pneumonia with the pleural effusion means that this patient is going to have a pleural effusion on dasatinib, and it may be among the less morbid side effects that you could manage if it recurred. You wouldn't want a 62-year-old man might have more cardiovascular disease than you actually know, so that would be worth looking into. Not that nilotinib is a bad choice. I think it just could be more complicated. And I think bosutinib is now a frontline option, and it's unclear how much effect it would have on renal insufficiency. I think it certainly could, but it also has some other subjective and objective toxicities that can happen early, liver enzyme elevations and GI toxicity. So I don't know how others feel about it.
With nilotinib, hypertension, the cumulative risk of cardiovascular events in NSND is 12% over 6 years, 2% per year. I feel more comfortable with either dasatinib or bosutinib. I would use 50% dose reduction of dasatinib. We have a trial with 50 milligrams per day. We did not see mainly pleural effusions. And this man, as Mike mentioned, had only one episode of pneumonia. We all could have had in our life a pneumonia one episode. It doesn't seem to be really controversial. Yes, and then finally for bosutinib, yes, it does lower the clearance by 20%, but that is reversible. I will use 400 milligrams or lower. So these two options, I will feel comfortable with either one.
Good. I think it's well outlined that we have some options there, and the past medical history is certainly really important here.